We're going to go ahead and get started. Welcome, everyone, and welcome to Critical Conversations, a cancer learning series. This is forum number 1, Lung Cancer Screening, a Beginner's Guide, featuring our very own Mark G. Goldstein, MD, FACP, and he is joining us from the Center for Cancer and Blood Disorders. This series is hosted by the Oncology Foundation of Maryland and the District of Columbia. And our mission is to bring together in a non-competing forum patients, patient advocates, doctors, and the research industry to provide education and information on available cancer resources. I am Yolanda Johnson. I'm your facilitator for this evening, and I'm representing the Oncology Foundation. I'd like to talk a little bit about our guest and give you some key points. Our guest, Dr. Mark Goldstein, just some really great things about him. For one, he's an expert in what he does. He is currently a husband and a father. He is currently practicing out of the Center for Cancer and Blood Disorders in Bethesda, Maryland. He also helped to develop a cancer survivorship program, and then he moved into focusing on lung cancer screening. So you'll get to hear a lot from him about that. But one of the things that I learned just from working with Dr. Goldstein over the past few weeks is that he has some funny parts to him. And so I want to share a little something so that he can tell you, show his funny side. How about that? We're going to give him the opportunity to show his funny side.
Good evening.
Good evening.
I don't do stand-up comedian, I don't do that, but so thank you for the introduction, and Yolanda, thank you for everything you've done to help with this. And I have to start by thanking Pam and Pat from Oncology Foundation and Maryland DC Society of Clinical Oncology for helping put this together. This is about a 1-year culmination of efforts that is just the tip of the iceberg. We hope to really expand this out because I have a big concern, as you'll hear in a minute, about the situation with lung cancer, not just in Maryland, but just everywhere in this country. So this picture is one of many sort of comical pictures, really, from Norman Rockwell. And there's several, we were trying to pick one, but there were some, funny ones with children smoking. I mean, it doesn't sound so funny, but they're interesting pictures, and even, pictures of doctors smoking and things like that. And, he was able to capture these sort of caricatures and this is decades ago. And right now we think how ludicrous it would be for doctors lighting up a cigarette in a meeting or something. But that stuff used to really go on. And the pictures like this one, or pictures of the kids, really reminds you that there's a lot of people out there who've been exposed, sometimes years ago. And what I do every day, one of the things I do every day is deal with the consequences of that and help patients through that. Majority of lung cancer cases don't need to show up advanced. They can be caught early. And so we'll talk about that a little bit more.
Awesome. Thank you, Dr. Goldstein. I just wanted you all to know, if you're just coming in, we have started. You just kind of missed an introduction, so you haven't missed a lot at this time. What we're going to do is Dr. Goldstein is going to share a few graphics to give you a good visual of things related to lung cancer screening. And then he and I are going to go into some dialogue, and we're going to have space right after that to do some good Q&A with all of you. So if you have questions or thoughts as we're talking, keep them in mind or jot them down so that we can talk to you about them later on.
And this is meant to be very informal. This is not an academic lecture. It is not meant at a physician level. It's meant for just anyone who's interested to understand the basics of this. And again, the premise is to start the conversation and really get the word out, because we really want to bend the curve here on screening. So why is it that this is such a big deal? Well, if you look on the left side of the pie chart, these are new cases of cancer, not specific to lung cancer, and this is an estimate for 2022, and you can see in the reddish color, if that's coming through okay, that roughly 12% of these new cancer cases are lung cancer. But if you look on the right-hand side, what you see is that there's a higher percentage of cancer-related deaths coming from the lung cancer group. We know that a lot of breast cancer cases are caught early because of mammography, and we know that the treatments have gotten better and better over the years. We're starting to make some headway in lung cancer as well, of course, but it's just really a problem. And as we talk further about this, the treatments available for advanced lung cancer, although they may be less toxic, they're incredibly expensive. And if you do the number crunching, it's just not sustainable. I mean, it's not what we want, irregardless, for patients to show up with advanced cancers. We don't want that. But if we're just not going to screen anybody, then many patients are going to show up with advanced cancers, and it's bad for the patients. It's bad for everybody. Financially, it's completely unsustainable. So what we want to try to do is change those numbers. Simply, this is just, it's not the greatest graph in the world, but it's trying to show that if you found a population of people, and I'll talk about how this was figured out several years back, but if you capture a demographic of patients, in this case, it says at the top, patients at risk for lung cancer, age 55 to 80, and these patients, let's say, were supposed to get screened. And over the course of years, how many people were really getting this? And you can see it's somewhere in the 4 to 5% range, and that's just not going to work. And because you're missing a huge chunk of people who are eventually going to get a lung cancer, and perhaps that could have been caught earlier. And that's what we want. We know it doesn't matter what cancer you can pick. If you catch it at an earlier stage, the treatments are easier on the patients and survival outcomes are always superior. That's why we have a staging system. So if we were to send someone to get lung cancer screening, what is that? I mean, a lot of patients don't know. They know what mammogram is, right? And they know what colonoscopies are, generally. Most people do. But what is lung cancer screening? Well, it used to be that people were getting, you go for an annual checkup, you get a chest x-ray and that kind of thing. But almost a decade ago, it was sorted out that a CT scan was superior to chest x-rays in detecting lung cancers. And so this is a picture of a machine like that, where a patient would lay on the table and go through the little donut hole there, and very quickly would have detailed imaging of the lungs. And they don't need IV contrast, so you don't have to worry about kidney function. They don't have to drink anything. And it's a fairly quick test. Patients who might consider themselves claustrophobic don't have to worry too much, because it's not an MRI where you're in there for an hour. It's actually quite easy for patients to do. I would argue a much easier screening test than either mammogram or colonoscopy by far. And so it can be a very valuable test for patients and quite easy to do. The radiation exposure is certainly not something that we want to overlook, but it is actually quite a small amount of radiation, relatively speaking. We can get into some details if we want later, but a lot of patients worry about that, and it's understandable. But at the same time, it's not that much radiation, and the cumulative side effect of that radiation is thought to be minimal, and the risk benefit is far in favor of doing screening, I would argue. There's a lot of debate about that, which again we'll touch on a little bit during the conversation, I'm sure. But I just want to give you an idea. If you weren't sure what a CT scan looked like or how it's done, that's what it is. Now, this is just a random picture we found. I didn't want to use my own patient information, but this is just an example. You don't have to be a radiologist to see the red square, but this is an example of a nodule in a lung. A lot of patients, when they hear cancer, or specifically lung cancer, they don't have any real sense of what it looks like. They can imagine what they think it looks like, And depending on the size and location, it has all kinds of different implications. But just to give you a sense of what you could find on a CT scan, this is what you could see. So just to orient you a little bit, and I don't think I have a pointer, but Yolanda, I don't know if you can help me with that. But if not, it's okay. On your left side of the screen is the right lung, okay? And on the side with the red box, which should be your right side of the screen, is actually the left lung. And the glob in the oops, there we go, that's okay. So, and sort of toward the top there, that roundish structure, it's a little hard to see, I admit, on this picture, but that's the heart. And the round white structure almost right in the middle there, behind the heart, which is lower on your screen, is the aorta, the main artery. And behind that is the spine. So just to kind of give you a little orientation, but that on the left side is a lung nodule. I don't want to call it lung cancer. I call it a lung nodule. You can't know for sure until it's biopsied. And that's a really important point as well, because one of the concerns that has been raised about lung cancer screening is, what about finding things that aren't cancer? Wouldn't that be a problem? Wouldn't it worry a patient? And then they have to go through an invasive procedure to find out whether or not it's cancer. And that's all true. There are concerns about that, but some of that concern is less of a problem now than it was years ago. The technology of the imaging machines is superior now, but also what we have now is a more standardized way of reporting. So the radiologists now have a method to their madness when reporting on lung cancer screening CT scans that better classifies the nodules and also gives specific instructions back to the referring physician saying, for this type of nodule, make sure to repeat the scan in, let's say, 6 months or something like that, if they don't think a biopsy is warranted. So patients aren't just dismissed, there's a process behind it. It's very similar to how mammograms are done. And there's a similar process for other cancers as well. It's all getting standardized now. So, and what that's been actually looked at, and by using this newer methodology and higher quality imaging, you actually get fewer false positives in general. And so that's just, again, this is meant to be a basic overview. We can get into as many details as you want. Now, several years back, 2013, it is just about a year or two after the study came out about lung cancer screening, CT scan versus chest x-ray. And at the time, there was a certain age restriction related to that, as well as a smoking habit history. So 30 pack years, for example, 1 pack a day for 30 years, or 2 packs a day for 15, something like that. And so that's just what they went with. And then fast forward to March 2021, and this thing got updated. And what you see here is the current guideline from the United States Preventative Task Force. So it's now expanded the criteria. So there's a wider age bracket, so age 50 to 80 years now, and 20 pack smoking history. So 1 pack a day for 20 years, or 2 packs a day for 10 years, or some other equivalent of that. And you notice it says that if they're currently smoking, okay, that makes sense. But what about if they quit? How long ago does that matter? Should it be 5, 10, 15, 20, 30 years ago? Well, they've come down to 15 years. I'm not a statistician, but I'm sure some of them were involved in all of this. And I've seen several reports trying to analyze whether or not this is a good idea or a bad idea. One thing that they have shown is that this new criteria ends up yielding less racial bias, and other biases are reduced. So you're missing fewer people. You're, and again, missing, when I say missing, I'm talking about simply just capturing the people who are supposed to be screened appropriately. This has nothing to do with whether or not they see the nodule. It's just simply, would that patient who is destined to get a lung cancer ever have gone to screening or not? And even despite this, you're still missing a large chunk of people who will eventually get a lung cancer who would never have qualified for screening. All they had to do is, let's say it's someone who's 70 years old and smoked 20 pack years, but they quit 17 years ago. They're out. They're not going to be screened. And most of us would scratch our heads and think that that doesn't make any sense, you know? So I usually will tell a patient, you know, you don't make the cut for screening, but if you get a cough or get anything, I want you to get tested right away, or at least call me or call your doctor. Because we recognize the flaws in this, but this is what we have now. And now this is just the guideline, the recommendation from United States Preventive Task Force, but actually Medicare has come around and they do support this and pay for this. And so that's an important piece as well. Now, if one qualified, you saw the CT scan. How often would you go? Well, similar to a mammogram, you'd go once a year. The original data was for 3 years, but they allow for patients to continue going once a year if it's thought that the patient is at risk and that they're not in a medical situation that would make it impractical. So if it was someone who is, 80 years old, but they're, incredibly sick from some other problem, you're not going to screen that patient. For example, they've got other health problems that they have to worry about, for example. So this is just to demonstrate that my little project here, which I hope to become a big project, we are not the only ones looking to do this. There are multiple organizations you can see here that are basically in the same camp. Some of these promotional things are, well, most of them are not specific to lung cancer. They're just telling people to go get screened and catch things early. But some of what they're doing is lung cancer specific. And I think that's great because, most people are aware in October, there's pink ribbons everywhere, and that's good. We want to raise awareness for breast cancer screening and all that. But November is the next month and no one has a clue about lung cancer screening. I've asked so many patients of mine with stage 3, stage 4 lung cancer, did you ever get screened? And they're like, what are you talking about? I didn't know there was such a thing. And that's what I want to change. And it starts here with this meeting, and hopefully we'll, expand out to the state, work with them. The state of Maryland has some beginnings of a program there. And then, of course, there are national organizations, American Society of Clinical Oncology, thoracic societies, et cetera, that can help with this effort and make it easy for patients. But the reason we wanted to promote the event for the very first time to patients or families of patients, to you, is because that is, I think, where the push is going to come from. Patients can go to their physicians and say, hey, I heard I could get screened for lung cancer. I really want to do that. Why am I going for a mammogram and not lung cancer screening or something like that? We want to empower patients because we know that screening is just not happening. I mean, yeah, some states, maybe 5-10%, something like that, but of eligible patients, I want to see it way above 70% of eligible patients, and it's just not even happening. So I appreciate you letting me present this to you, and I have a lot more detailed stuff if we want to talk about that or venture into what happens when you get diagnosed or things like that. I'd be happy to open up to any of your questions.
Awesome. Thank you so much, Dr. Goldstein. We appreciate that. I want you all to, just think back to that one photo where it said that we are all in this together. Dr. Goldstein mentioned gave us a lot of rich information, but that one photo showed that this is a pretty global push to make sure that lung cancer screening is at the forefront of everyone's mind, and that we kind of know what to do when we're in situations or talking to our doctors. So Dr. Goldstein, just one follow-up question with you is, people like me, right, and some of us on the line, if we're going to our doctors and say we're in that age range and maybe we had some smoking in our past and maybe we just don't know, how do we advocate for ourselves with our physician to even bring up the conversation about lung screening?
Right. Oh, I think one of the easiest times to do it is when they're talking about other screening, right? So they might talk about osteoporosis screening or thyroid or mammograms or colonoscopies. Anytime they're talking about something like that, that's a great time to say, well, I smoked. Is there anything you can do for that? Like that would be the starting point. And they say, oh yeah, there's this thing called lung cancer screening. Now, if they look at you with a like deer in the headlights, I mean, that's a little concerning, but that's okay. I mean, you can still say, hey, I heard about this. Can you check it out for me and see if I could qualify? We have that. I think it was the last slide that had the screening criteria, the current screening criteria. I mean, that's something we can, share with you, I guess, through some link. And you could just print it out and bring it with you and say, hey, doc, is this something that that you think would be good for me? Something like that.
Good, good. Thank you so much for that. And thank you for sharing earlier that, there were some disparities, but there were some changes made so that folks can have better access to lung cancer screening. Are there still current changes happening right now that we need to kind of be aware of or think about?
So when it comes to this set of guidelines, not really, but there are other people looking at this. So for example, there's other screening criteria out there that can be used in isolation, or they can be used in combination with blood tests. They call them biomarkers. And there's one that you get 4 blood tests together, and you use that in combination with one of the screening criteria, which is similar to the one that we showed. And there's some reason to believe that that is superior, meaning that you're capturing the right people better than if you use just this criteria alone. But that is not mainstream yet. And it's an evolution, so we're waiting to see what happens with that. Even if let's say a physician was pushing the envelope a little bit, which is fine, and they use that new screening criteria along with the blood biomarkers because they just think that that's better, that's okay. But that doesn't mean Medicare will pay based on that, because right now they're only, to my understanding, paying if you use the criteria we showed from the United States Preventative Task Force. So, but there are changes coming, and that's good. But you're talking about, instead of like what is it called, Moore's law, whereas constant iterations, and you're not going to get that with this. It's going to be too slow. So it might be 1 decade at a time you're going to get an update or something. So for now, we just want to use what we've got, because right now we're not even using that.
Yeah. Thank you so much for sharing that. Before we move into some just Q&A with our guests, one of the things that came up during our discussion is what do we say to our family members when they ask us about the risks of marijuana and vaping and things like that? What do we say to them?
Wow, that I wasn't expecting that one tonight. Well, I think the jury's not out yet on all the details of this, but certainly there have been congressional hearings and they've had people testify and say how certain products are addictive, and that's a problem. And they've identified carcinogens in some of that vaping material, and that's concerning. But the long-term effects we don't know, because with that particular product, because it's only been around for a while, right? It's fairly new. And if you look at the trajectory for lung cancer, you're talking about people who we're seeing now who are 80 years old, but they started smoking, or they're presenting with cancer at 80 years old, but they were smoking when they were 20, 30, 40 years. It might take decades before the cancer shows up. So I don't think we know yet specifically about that one, other than we know it's probably not a good idea. Marijuana, it's probably not the fact that it's marijuana versus a regular tobacco leaf. It's the stuff that's burning off. I mean, it's anytime you're inhaling smoky material, whether it's, right out of the chimney or, thank you. Yeah, right. Or pollution, or anything that's been burning and you're inhaling it in some way. You can even argue ingesting it. Smoked meats, for example, we know that has carcinogens in it, and it potentially can increase the risk for colon cancer or stomach cancer. So these smoke itself just gives off chemicals, and so probably there's some we can't say that smoking marijuana necessarily is safe, right?
Right. Thank you so much. So we'd love to hear from all of you. You've heard a lot from us, but we want to hear from all of you. If you have some thoughts, feedback, or even just a question that you would like for us to kind of dialogue about, feel free to take yourself off mute.
This is Pam Pyro. So I would have a question. One of the things that I was surprised, if you will, disappointed, was that many people just are still not willing to discuss this topic for a variety of reasons. Part of it's stigma, part of it's fear. So maybe what would the typical treatment schedule or protocol look like for someone stage 4 to stage 2, et cetera, to help them not be afraid if they have an early diagnosis?
Right. Yeah. Well, case in point, I just saw a patient just today who had an incidental finding of a lung nodule, but it could have just as well been screening, and hers was stage 1A. So what would that treatment look like, other than the biopsy that she had to go through? But, well, the treatment basically for most people like that, is just straightforward surgery. Surgery used to be an open surgery of the chest, but now they can do it laparoscopically, so with the cameras, so it's much quicker recovery and safer, I would argue. I'm not a surgeon, but that's generally how it goes. And an alternative for a patient who can't have surgery would be a form of radiations. Some branded ones are called CyberKnife, for example, where they pinpoint the lesion. There are some nuances with that, because as you breathe, the lung is moving up and down, and so they would have to put a piece of gold called a gold fiducial in there at the time of biopsy, and the robotic arm will track the gold particle as you breathe, and so it can't miss, and you can obliterate that. And so for early stage, when I say early stage, that's not the right term. For stage 1, you can get away with that. Early stage in oncology, I never like that term, because they call stage 2 early stage, and they call stage 3 early stage, and they only call stage 4 advanced. It doesn't, that doesn't make sense, especially when you look at the prognosis for stage 3. So for stage 1, which is truly early, that's what the treatment would be like. It's no picnic, but it's pretty straightforward. It doesn't require chemo therapy or immunotherapy or any of that. Now, on the other end of the spectrum is stage 4, which means metastatic cancer. And that is actually quite a complicated subject. When I started training in 2005, basically what we had was chemotherapy. It was a little while after that immunotherapy started coming out. And we can talk about that a little bit if you want, but basically these are antibody treatments, and they were able to show in certain circumstances, you have to combine the chemo and the antibody, but in other circumstances, you can just do the antibody only. You don't have to take chemotherapy. It can work really well with very few toxicities. And I've seen some patients do very well with that. In other cases, we found that there are gene mutations in these tumors. And so instead of giving either chemotherapy or immunotherapy, you give them a pill which targets it, which is very similar to the concept of giving tamoxifen for breast cancer. It's a simple treatment. These medicines are a bit complicated compared to tamoxifen, so they have a certain number of side effects you have to watch out for. But there are several of them on the market, and they're actually very helpful, but you have to have the right gene mutation. Otherwise, you can't have that pill. So, and of course, if it's stage 4, you're going to be on treatment indefinitely. And at some point, the cancer will then become resistant, and you have to change treatment to something else, and on and on. Now, many patients with stage 3 will get a combination of chemotherapy and radiation therapy. And then at the end of that, some of those patients will get immunotherapy. They just won't get it all at the same time, they'll spread it out. So in many cases, stage 2 patients, they may have surgery, but they're going to get chemotherapy and usually not radiation therapy. But there's so many layers to this in the stage 2 and stage 3 segment that it would be really hard to cover in a situation like this. But those patients, anyone beyond stage 1A, which is the smallest of the small tumors, right? Everybody else is going to have a complicated regimen to follow. There's going to be toxicities. And unfortunately, their prognosis is just going to be worse, no matter, what treatment we pick, than a stage 1 patient.
That's really helpful.
Hi, this is Susan Nolte. I'm one of the board members. I know we want to increase awareness so that people will ask for these tests. And I was wondering if we could, if the doctors could be on the lookout for a high profile patient who would be willing to do this after they've had a success, and be willing to do it as a public service to tell their story, and be someone that would not mind if we would publicize it and try to use that to bring awareness up.
Yeah, no, I think that's a phenomenal idea. I am yet to meet that patient. If you know somebody, please tell them to call me because I'm telling you, I've been practicing in Maryland since December 2009. And I can count on one hand the number of patients I've seen who got captured with lung cancer screening. I mean, they're just not, now they may be out there and I may not meet them all because they might go, let's say they have COPD from smoking. They go to their lung doctor on a regular basis and they do the screening. A 1 centimeter nodule is found. They go to the surgeon, it gets pulled out. They never meet the oncologist. That's possible. I'm sure that's going on out there. But I am not seeing those patients. I only seem to be seeing, except the lady I saw today, who didn't get captured through screening. She got captured incidentally for some other problems she had. But other than her, I'm almost exclusively seeing stage 3 and stage 4 patients. And that's just how it's been for the last 10 years for me.
Thank you so much. Thank you for sharing that, Susan. Madeline, did you have a question?
Yes, thank you. Doctor, in your effort to raise more awareness of screening tests for lung cancer, what are the primary barriers that you have observed from HMOs and primary care doctors? And how do you suggest we as patients address those barriers in an educated way?
Right, that's great. So I have personally spoken to a variety of primary care doctors and some of the lung doctors about these things. Some of them, or most of them nowadays, have computer systems that automatically alert the physician and say, ding, ding, you should offer lung cancer screening to this patient. And a good friend of mine who's in family practice and just over the line in Virginia, they train residents actually. And so they do it as part of the practice as a whole and train the residents to do it so that they're aware of it. So when they become internists, go out to practice, they're doing it. So computer systems are somewhat helpful, but the problem on the flip side is the computer systems over alert physicians and they're just clicking stuff to get it off the screen so they can focus on the medical side. So you can get, too many alerts. But it's certainly a good idea to have patients advocate for themselves and ask their physician or ask their practice, do you, what do you think about lung cancer screening? There certainly are practices out there that still have paper charts. Not that that's a terrible thing. I miss that sometimes, but they just don't have the same alert system. But there's just certain doctors who don't think it's a good idea to do lung cancer screening because there's false positives sometimes. So there's philosophical differences. We're not having, to my knowledge, problems with, I think you said HMOs and things. I don't think there's any problem there because we know that Medicare pays for it. So the other insurances usually pay for things too. And I'm sure at some point, and this might already be happening in certain practices behind the scenes, that there are quality control, quality improvement projects where the powers that be are looking at how the doctors are practicing. And if they're not ordering enough lung cancer screenings for the eligible population, they're going to say something. Just before this meeting, I was on a Zoom call with Holy Cross Germantown, and they do the same thing all the other hospitals do. They are for the inpatient side, they have, you know what secret shoppers are, right? So they have these sort of secret shoppers walking around the hospital looking to see who washes their hands.
Good.
Okay. And they look at everybody, the janitors, the doctors. It used to be the doctors were the worst, by the way. We're caught up now. Okay. But I saw the data on it today, you know, and you can see who's washing their hands, who's not. I mean, if they can do that, they can easily monitor practices and see what their prescribing habits are for lung cancer screening in their population. And if they're not screening above a certain number, we know that that's a problem, right?
Dr.
So
Goldstein, I'm sorry.
I'm sorry. I'm just saying it's sort of practice to practice dependent, you know?
Practice to practice, that makes a difference. She actually brought up a really good point, and I'm wondering if all cancer centers actually have like a patient advocacy group or some type of patient liaison to help those folks who are not as you know, maybe educated or articulate, and maybe do feel a little intimidated with their insurance or with the doctors. Do most of the cancer centers have that type of support?
What, just to clarify, what kind of support you mean?
To help them navigate talking to the doctors, help them navigate
Oh, I
talking to
see.
their insurances?
Well, you're going to have different people doing different things. So if it's someone in a cancer center, for example, and like I'm in private practice, for example, so I don't have a social worker here necessarily, but a cancer center, like at a hospital system or a university, they're going to have navigators, social workers, and all the rest. But it depends on what their duties are, right? So a patient navigator for someone who has a cancer diagnosis, they're trying to help the patient not get lost in the system as they go from this specialist to that specialist and get procedures and tests done. So their role is very different. They're not going to do that. But as you mentioned before, I started a cancer survivorship program up in Frederick several years back that's still up and running. And one of the aspects of that is, let's say a patient's, you know, got through their breast cancer treatment. Well, now we want to, they have their captive audience for general health improvements, cholesterol, exercise, all of that. Well, that includes smoking cessation. And if it's known that those patients had smoked, but they were just, you know, in the throes of dealing with their breast cancer, this is a good time to offer them lung cancer screening. And I think that oncology practice in particular have a unique role there, because we know when the patients are done with their treatment, we know what they need to do to take care of themselves after their treatment is done. And I'll be honest, I don't think that we do a good job, even as oncologists, to say to those patients, hey, you know, remember that smoking thing, you know, maybe now that you're getting back on track and you're done with your cancer treatment for your breast cancer, why don't we make sure we take care of everything else? And that's colonoscopy and lung cancer screening, CT scan, and whatever they need. And that's part of cancer survivorship. And you know, not just from me, but the guidelines even mention, you know, about things like smoking cessation and those things in the guidelines for cancer survivorship. So those are opportunities that are missed again, you know, over and over again.
Thank you so much. I'm wondering if we have another question, or even someone who maybe has had some experiences with something like this. We'd love to hear from you. Feel free to unmute yourself. Any caregivers or friends on the line and have any experiences with folks who have been going through lung cancer?
I'd just be curious if there's anyone in the audience who has a smoking history. I won't get into the details of the criteria, but you have a significant smoking history. And in the past 10 years, were you offered lung cancer screening? That's all. I'm just kind of curious if anyone has been offered that.
Good
Of the patients who have not had cancer, let's put it that way. If there's anybody, I can't see everybody, but is nobody?
Anyone offered lung cancer screening at all?
No. And if there's anyone who's here who has a lung cancer history, or know someone with a lung cancer history in the last 10 years, were they offered screening before their diagnosis? Nobody, right? I'm sure there's a couple of people out there who've, you know, I mean, you wouldn't have signed up for this Zoom if you had no connection here, I think, but.
Dr. Goldstein, oh, go ahead, I'm sorry.
We have one, Dr. Goldstein. Vivian?
Hi, my name is Vivian Kerr, and yeah, I was a former smoker. I've been smoke-free for 3 years now. And I just recently had a physical, and going by the PEC years, my physician says that I did not need to be screened because
Okay.
I was not a heavy smoker. But listening to this today, I'm thinking maybe I should just go ahead and get it done anyway.
So, okay. I mean, it's up to you if you want to share, but you don't have to. But if you want to share your age and how much smoking you had, I'm just curious where they would
Well, I'm
categorize
50.
you.
I'm 51 years old, and I smoke probably about half a pack of cigarettes a day. From the age, very early age, probably from the age of 14, 15
Until 3 years ago?
until about 3 years ago.
Right.
Yeah.
So 48. So yeah, I mean, so, if we kind of rounded the numbers a little bit, right?
Right.
Yeah. So that's, 34 total years, right?
Yeah.
And half pack per day makes a 17 pack year. So if the cutoff is 20 pack years and you're at 17 pack years, you almost made the cut, right? I mean, you're really
Right.
close. So
Right.
on one hand, they're correct. You don't meet criteria officially, but you are quite close.
Close.
Um,
Yeah.
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 And age
Yeah.
of 50 qualifies you now. So
Right.
you could negotiate if you want.
Right.
It's hard because it wouldn't be covered. Well, Medicare wouldn't cover it, but I assume you don't have Medicare right now, but you could nudge a little bit and say,
Right.
I missed the cut by 3, back years. And I am not, by the way, suggesting you just start sticking up smoking and fill in those last 3 years. Okay. Don't do that. Okay. But, and then the other thing is, like I said to you earlier, which is just the slightest cough or something's just not right, go get
Right.
checked out. Now that's officially not screening once you've got a symptom, but
Right.
that's
Right.
fine. Just tell them you've
Right.
got a symptom and let them chase it down, because remember what I said before, the screening criteria are inadequate. We know they're inadequate. It's been widely published. It's imperfect, but it's the only tool we have
Right.
that at least Medicare recognizes and pays for that I'm aware of. But you and I both know that you're a risk, right?
Right.
So you just don't want to overlook that.
All right, thanks for that. And I had another question. I did mention that I have a friend who's currently, she actually is in hospice right now. She has, of course, advanced stage lung cancer, but, my question is lung cancer, I guess it's very hard to treat, or I guess she was just that far advanced. At this point, there's not much, they can do because it's spread now, but she chose to stop treatment a few, I guess last year sometimes, she just stopped treatment because she wasn't feeling well. It was just making her sicker.
Right. Right. I mean, that certainly happens. Absolutely. I don't like Monday morning quarterbacking not that we're doing that, but I'm just saying in general, I try not to Monday morning quarterback other doctors.
Right.
But I can tell you how difficult it is that when a patient shows up and they've got, when patients show up, they can have, you might say stage 4, or they can have stage 4, right? Like they can have a single nodule, one mass in the lung and one in the brain, and that's stage 4. And I've had patients go into remission, and they were in remission for 5+ years without being on an ongoing treatment. And have other patients just in the past year or so that they showed up so sick that I couldn't even get near them to give them cycle 1 of any treatment. And 2 of those patients ended up having strokes before I even got to give them their first dose of treatment. They were so incredibly ill. And in my view, this is completely avoidable in a lot of patients' cases, if they get screened. And I'm personally, I'll just be very frank, I am very tired of seeing these poor patients coming in so sick, and it's a Herculean effort to get things done for them. And if I have time, I'll give you one quick anecdote, a quick example If that, Yolanda, are we okay to do that?
Dr. Goldstein, I just wanted to say to everyone who is here, thank you so much.
Yes,
We
thank you.
are going to go over because Dr. Goldstein is willing to stay around longer for those who still want to hear more or have some more questions. But if you do need to drop off, it's okay. And we want to stay in contact with you. So follow us, follow along with the Oncology Foundation, but please stay if you're willing to stay and want to hear a little bit more.
Thank you, everybody who came. Really appreciate it. This was a great turnout for our first time event. And the organizers will be putting on more events for other topics and have a whole series, you know, for educational purposes that people can go back and look at these videos and learn from them.
Yeah. Doesn't look like anybody's jumping off, Dr. Goldstein.
Okay.
So I think
Right.
you should just
I got
keep
all night.
going.
Yeah. Yeah, I mean, but so there's a gentleman I saw not long ago, and and unfortunately I've seen a few of these cases lately too, but basically he had evidence of stage 4 lung cancer a few months before I even met him, and no one did a biopsy, and they just let it go. And he came in and he was in so much pain. He had cancer in the bones, and but we worked him up, and he had cancer in the brain. And one of the areas in the bones that was involved is the left and the right femur, right, the thigh bone right at the top. And the problem with that is, with any bone that's got cancer in it, is it could break, but that's a weight-bearing bone. So in the middle of a workup, we had to arrange for this guy to who had limited transportation, and get him to a radiation doctor to treat the tumor in the brain. We had to get him to an orthopedic surgeon at Hopkins to take him to emergency surgery to stabilize the bone, put metal, you know, rod in there before it breaks. You know, you usually think if you wait till something breaks and then you do the surgery, but by the time that happens, he's in worse shape. So we send him to surgery prophylactically to stabilize the bone. And then we put him on chemo and immunotherapy. And he was on a lot of narcotics for pain control. And now it's been about 3 months, and his blood test tumor markers are dropping. His pain is down. His mobility is increased. He's completed the radiation to the brain. And I think he's getting radiation to the bone that got surgery on it. And his functionality is improved. But it was a Herculean effort for this guy and for us to get him to everywhere he needed to go. And we had to do it quickly because he was going to die. And that's the kind of stuff that, you know, we don't want to see. It's bad. Like I said before, it's bad for patients. It's just hard on everybody. It's incredibly expensive. And now that he's turning the corner, and he's probably going to stay on treatment for a while. You know, some of these immunotherapy drugs, it's $10,000 a dose, and you're taking those, you know, maybe every 3 weeks or so. That adds up real fast. And can you imagine all those patients out there where a good chunk of them are getting immunotherapy, and if they're getting a targeted pill, it's still $10,000 a month. I mean, these are huge expenses for patients. Whereas a CT scan of the chest, I think before Medicare was paying, I think it was like $70, you know, and, you know, it might be a couple thousand to get the biopsy and the surgery done and for stage 1, and you're done. Right. So, you know, they've done quality cost effectiveness analyses and clearly demonstrated that lung cancer screening, even though it's not perfect, is a cost effective strategy. And the number needed to evaluate is somewhere around 300. So it depends on what study you look at, but for every roughly 300 people you screen, you're going to save 1 life. So I think that's worth it.
Yeah. You know, Dr. Goldstein, I was thinking when I posted this on LinkedIn, I had someone who inboxed me and said, wow, you know, I just looked up lung cancer and I didn't know that it was so prominent. like in just such a like high up there. People don't think of it. What is it that we can do to kind of push the word out? Like, we're going to be sharing within our families. We've been doing that. Our board members have been doing that. How can we push the word out more? Of course, we're not the NFL or the big
Yeah.
stand up for
Well,
cancer, but what can we do as individuals to help this out and push this along?
well, if you're someone who's in the line of advocacy and that kind of stuff, you don't need to, I don't think, go to your congressman or those kinds of things. They've already approved screening to be paid for by Medicare. So we're over, that's good. But now it's just really a matter of getting the word out to other patients. And I'm not on social media, but if you are and you know how to do that, by all means, get the word out to people who smoked and could qualify, and encourage them to just ask their doctor about it. Um, and if you want to work with one of those organizations or work with us, that's great. I mean, we're again, this is a fledgling project right now, but I have big plans for this. And when I joined Maryland Disease Society of Clinical Oncology, the first meeting I was there, I told them this is what I want to do, and I want it to go. Well, I think I mentioned nationwide, but I was willing to start with Maryland. But we really need to get the word out, and that is what we need help with. So anybody who's out there who wants to somehow make these connections and work with us, that would be fantastic, and ultimately get the word out. So I think most importantly to the patients, and they will then go to their doctors and talk about it.
Awesome, thank you. And we'll talk more in our board meetings about like maybe how we can give some folks some things to follow up and send out to their communities, because there is 21 people on this call, so that's 21 different communities that we can get information out to. Pam, did you have something?
No, thank you.
Okay.
Just wanted to thank
questions?
Thank you. Thank you both very much. I did want to touch on something really quick. Dr. Goldstein, you mentioned about people not being asked by their doctor. And I think I'd mentioned this too. I talked a couple of days ago to a gentleman, a very successful entrepreneur, who in 2018 was given us just a normal chest x-ray as part of his exam, even though he had a smoking history. And it was totally clear. 6 months later, he was found to have because he couldn't get rid of a bronchitis, and they went and a chest CT scan, hit stage 4 metastatic breast cancer. Simply, and that's the CT scan and how powerful it is.
Yeah, I mean, I showed you that one picture, and you can see a lot of detail in that CT scan picture. And your chest X-ray just doesn't cut it. I mean, you can't see much. Chest X-ray, it's okay for maybe pneumonia or looking for a cracked rib or something like that, or if there's a really big tumor, but for a smaller tumor like the ones we're looking for, it's not. I mean, you have to have a high quality of image, and you have to have a very astute, not overworked radiologist who is picking through all that. Because remember, a chest X-ray is usually 2 views. It's really pretty easy, time wise, and the mental strain is there. And I'm saying this because my dad's a radiologist, his brother's a radiologist, and my grandfather's a radiologist. So I'm pretty familiar with what they have to do on a day-to-day basis. And it is exhausting what they have to do. We really take it for granted what they do. And you imagine a full body CT, chest, abdomen, and pelvis. You think of all the anatomic parts that patients have in them, and they have to detail every one of them. And they're one of those scans can easily push 500 images for one patient, and they're doing it all day long, right? It's exhausting. And to find those needles in the haystack. Now and then when you go to a chest X-ray and you say, oh, well, it looks good, next case, they're not going to spend an hour combing through a chest X-ray. They're going to spend a couple of minutes. So, and those nodules are just not going to jump out. The small ones, like the one I showed you, usually doesn't jump out at a radiologist. They might see it if they're lucky, but they might not. It depends on how dense it is too. Well, that's really unfortunate. I'm sorry to hear that. And if he was like we talked about, and if he qualified for lung cancer screening and wasn't offered it, I don't
The
know.
tragedy goes on. His wife had asked for then follow-up for CT scan, and the doctor would not allow her to have it. Even she offered to pay for it herself, but that's another story.
Yeah,
So
that
it's the
sounds
battle
very
itself is
problematic.
it does very problematic.
Very problematic. Yeah, but he, you know, he's got his hands full, I'm sure, with that situation. But I mean, maybe that will trigger something for the doctor for the future to be very proactive about lung cancer screening. I should hope.
I would hope so too.
Thank you.
So,
Anyone else? We may be able to take one more.
I just wanted to thank you, Dr. Goldstein and Yolanda, for the wonderful presentation. I've learned a lot. It was very, very clear, simple to understand, kind of overwhelming in many regards, but thank you for undertaking this initiative. And I'm going to definitely get this out to my social media friends.
Great.
Thank you.
Thank you so
That's
much. And thank
wonderful,
you for being
Diane.
here. Appreciate that.
Thank you all so much. Dr. Goldstein, we want to all thank you, just for your candid conversation and just the honesty as well, just so that we can have an idea of what's going on in the medical profession. We don't always hear that. And so, we appreciate you just kind of being honest with us and saying, these are some things that we don't know, and these are some things that we may need to do better. And thank you for being an advocate for lung cancer screening and pushing out there. We just have some thank yous in the chat. But if does anyone else have any final thoughts?
I think what we're touching on what Dr. Goldstein said is that we will be utilizing what we learned from this session and developing a plan for how we can take this going forward to help spread the word and how we form other educational sessions. So thank you, Dr. Goldstein. Thank you, Yolanda, and thank you everyone for participating.
Thank you.
Absolutely.
Thank you so much
This
for
was
having me.
great. This was great. Thank you all so much. We're going to go ahead and end it out now. Have a great night.